good evening and good afternoon to our speakers, chairs, and viewers of the ACNS webinars in various parts of the world. We are back again with another week of insightful lectures for you. The first speaker for today is Professor Angelos Kolias from the United Kingdom. Professor Kolias is a lecturer in neurosurgery as well as an associate director NIHR Global Health Research Group on neurotrauma from the Iden Brooks Hospital and University of Cambridge, UK. He is also the chairman of the Young Neurosurgeon Forum of the WFNS. His neurosurgical interests include neurotrauma, anterior skull-based pituitary surgery, and spine surgery. He is also interested in the methodology of clinical neurosurgical research, particularly trials and global neurosurgery. He was an active member of all the major research trials published from the UK regarding traumatic brain injury in the last decade. We are extremely thankful to him for accepting our invitation to be a speaker at our webinars. Today, he is going to talk about the results of the latest DEX CSDH study published in the NEJM. The second speaker for today is our honored guest from Japan, Professor Kenichi Oyama. Professor Oyama is the director and professor of Department of Neurosurgery at the International University of Health and Welfare Mita Hospital, Tokyo. His research interests include anterior skull base and spine surgery as well. He is a noted author who has published several articles in various peer-reviewed journals. He was a previous fellow at the Pittsburgh and Paris, and we are extremely thankful to Professor Oyama for accepting our invitation to be a speaker at today's webinar. He is going to talk about endoscopic endonasal surgery, the sagittal plane module. The chair for the first session for today is our honored guest from Pakistan, Professor Tariq Khan. Professor Khan is the Dean of the Northwest School of Medicine located in Peshawar, Pakistan, and Professor and Head of the Department of Neurosurgery at Northwest General Hospital and Research Center. Dr. Khan is the Chairman of Neurotraumatology Committee of the WFNS and is Chairman of the Alliance Healthcare Limited, Pakistan. Dr. Khan is a member of Neurotrauma Committee and faculty of the Asian Australian Society of Neurological Surgeons as well as the Medical and Dental Academic Board of Pakistan, and he is the convener of the Neurotrauma Committee of Pakistan. We are extremely thankful to Professor Tariq Khan for lending his support for the ACNS webinars on more than one occasion. And we're looking forward to his valued comments at the end of the first lecture. The chair for the second session of today is Professor Paolo Capabianca. Professor Capabianca is a professor and chairman of neurological surgery at University of Napoli Federico II, Italy. He is also president of the Italian Society of Neurosurgery. Professor Capabianca is a giant in the field of endoscopic endonasal surgery and is an invited faculty to various workshops and conferences organized by various societies across the world. We are extremely thankful to him for his presence at today's webinars. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kata, I would like to sincerely welcome both the speakers and chairs to this online platform of ACNS webinars. Dr. Liu Bun Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this virtual platform to Professor Tariq Khan.
Hello, everyone. Welcome to this webinar. It gives me great pleasure and honor to welcome our friend Angelos Kolias from Cambridge to talk about dexamethasone and chronic subdural hematoma. Professor Kolias has got great experience and work in TBI and done a lot of research projects for everybody and continue to do the same. Dr. Kolias, please.
Yes, thank you very much for the very nice introduction. Also, thank you for the invitation. My particular thanks to Dr. Raja Kuti for being so accommodating, and of course to Professor Yoko Kato as the chairman of the ACNS, and of course to Professor Tariq Khan for his very nice introduction. Also our collaboration, which now goes back quite a few years in the global neurotrauma group. So I will share my screen. Dexamethasone for chronic subdural hematoma trial that we published in December, just gone in the New England Journal of Medicine. So that's the work of several people, and you can see all the main authors on the top there. You know, as I say, this is a huge collaborative effort, many people working together. So to be honest, even though I'm presenting the data, you know, I cannot say that this is my study. This is everyone's study. Everyone who participated played a major role. So why do this trial? You know, that's a very basic question. But, you know, I guess chronic subdural hematoma, we know that it is very common. Approximately 5,000 people over the age of 65 have a diagnosis of chronic subdural in the UK every year. Of course, not all of them need an evacuation, but still, evacuation of a chronic subdural is the most common emergency neurosurgical operation. There is good evidence that the incidence is rising. And that is recent data published in the JNS from the United States. And also we have some evidence that post-operative recurrence is associated with worse outcomes, so functional outcome at 6 months. And Thompson Tariq also from Cambridge with Prof. Hutchinson published back in 2009 now, so more than 10 years ago in the Lancet, the study randomized trial which showed that the use of a subdural drain reduced the risk of recurrence significantly and improves the outcomes at 6 months. And with steroids, it's one of those areas, I guess, steroids in neurosurgery have been contentious also in spinal cord injury, in head injury. So it's one of those controversial areas. And the same applies to chronic subdural. So there was some non-randomized evidence that steroids may be able to reduce recurrence. And also in some selected patients or patients with mild symptoms may even prevent the need for surgery. And I know that there are quite a few units, for example, in Netherlands, that they primarily treat with a trial of steroids and then operate if necessary. And you can see the previously published data. So the first report published back in the 1970s. Again, this is a small case series from the United States. And then you have a couple of systematic reviews there which have very different conclusions. So you can see the review published in Annals of Surgery back in 2014. So, a very good journal. And the conclusion was that the use of steroids as an adjunct is associated with a higher morbidity with no significant improvement in recurrence or cure rates. And then a review published in the European Journal of Neurology, again, a very good journal. The authors concluded that 5 observational studies suggest that steroids might be beneficial. However, there is a need for randomized trials. So very different conclusions. So the study design of the DEX-CSDH trial was that this is a pragmatic, randomized, placebo-controlled trial of a 2-week course of dexamethasone, and you can see the drug regimen there. So we started with relatively high dose steroids for the first 3 days, and then started tapering down every 3 days up to day 14, and then stop. It was a short course, so there was no need to carry on tapering any more than this, we thought. And the hypothesis was that dexamethasone compared with matching placebo, and that's important. So the placebo was identical to the dexamethasone. The tablets of the dexamethasone and the placebo were encapsulated, so they looked exactly the same. So the hypothesis was that dexamethasone improves a 6-month functional outcome in patients with a symptomatic chronic subdural by reducing the need for surgical interventions and postoperative recurrence. And we excluded patients if they had conditions where steroids were contraindicated, for example, an active systemic infection, recent peptic ulcer, or if they were receiving steroids recently within a month before screening, if they had a CSF shunt-related subdural, or if they had any history of psychosis in the past. The patients, the clinicians, and the researchers were all blinded. So this is the gold standard for a randomized trial of pharmacological interventions. And we were randomizing patients if we could start the medication, the placebo, the dexamethasone within 72 hours from admission to neurosurgical unit. And otherwise, the decision to do an operation to evacuate the subdural and the timing of that operation was left entirely at the discretion of the treating clinical team, the treating neurosurgeon. As I say, this was a pragmatic trial, so we felt that this was necessary. And in terms of the primary outcome, so we looked at the Modifier ranking scale at 6 months. And just a reminder, so the ranking scale, the range is from 0, where patients have no symptoms, up to 6, so those patients who have sadly died. And then you have a range of outcomes from no significant disability, so patients who only have mild symptoms, then slight disability, moderate disability, so these are patients who need some help, but they're able to walk unassisted. And then the more severe disability at 4 and 5. So these are patients who are unable to attend to own bodily needs without assistance. They cannot walk unassisted. And then 5 is those who are bedridden, so bedbound. And this was patient and proxy reported, but on the forms were centrally adjudicated by a blinded member of the research team. So the blinding was maintained here. And then the secondary outcomes, we have the MRS modifier ranking at discharge in 3 months, then the number of operations, the Glasgow Coma Scale, and then Bartel quality of life index, mortality, length of stay, and discharge destination, and also the adverse events, which is quite important. The health economic analysis is pending. So the statistical analysis plan showed that we needed a target sample size of 750 patients, so big study, and this was based on a power of provisional power of 81 to 92%, so that's pretty standard, with significance of 5%, again, pretty standard, aiming to look for a difference of 8% in the proportion of patients with a good outcome, so MRS of 0, 1, 2, or 3 between the two arms. So, you know, let's say if one arm had an 80% good outcome rate, the aim would be to detect if with the use of the medication, this could go up to 88. So the primary analysis, so we simply want to look at the absolute between group differences in the percentage of patients who had a good outcome. And this was an intention to treat analysis. Again, that's pretty standard. So we excluded only those who withdrew consent and those lost to follow-up. Secondary analysis, so we also did a per protocol analysis. So we excluded those patients who had less than 80% of the medication, or if they were given more than 8 milligrams of dex in the placebo group. And sometimes this happens because the anesthetists, they sometimes use it for post-operative nausea and vomiting. And then also we did some subgroup analysis, looking at various parameters such as age, the timing of head trauma, etc. And this is the recruitment. So you can see that the blue line was the predicted, and the actual recruitment is the gray line. So we started a little bit slow because of some delays with getting the approvals in every participating unit, but then you can see that actually the study recruited very well. So we got up to 750 within 2.5 years, pretty much. And you can see that we had a very good spread in a few different units in the UK, but most of the patients were randomized in Cambridge, Southampton, Glasgow, Leeds, Sheffield, Plymouth and Birmingham. And then you can see that several units actually participated. And this is the control diagram. So we had 750 patients randomized, but 2 were immediately excluded by the local investigators. And then 375 assigned to dexamethasone, 373 to placebo. And looking at the, going straight down into the 6 months, you can see that actually the loss to follow-up was not that high. So 5 lost to follow-up in the dexamethasone arm, 8 in the placebo, and 3 withdrew consent, and also a few other withdrawals of consent earlier on. So overall, we had more than 90%, so 91% compliance with a follow-up, which is quite high for such a population and for a multi-center study. And these are the results. So looking first at the baseline characteristics, and one thing to say is that these are pretty, all the baseline characteristics are pretty comparable between the two arms. So on the left, you have dexamethasone, on the right, placebo. The age is, as you expect, mean of about 75. Majority were male. And again, you can see that a variety of symptoms, but the things that you expect, so headache, gait disturbance, cognitive issues, hemparesis. And then again, you can see that most patients were significantly affected. The modifier ranking scale at admission, so that's the, this is not the pre-morbid, this is how the patients were at admission. So again, similar between the two arms, so patients were significantly affected. And again, GCS, as you expect, the vast majority have a GCS of 13 to 15. Some other additional data, so 70% were known to have a head trauma in the preceding weeks, and almost half were actually on some form of antithrombotic medication, so that's anticoagulant or aspirin, clopidogrel. And then 20% had a bilateral chronic subdural. In terms of the scans, again, comparable between the two arms, about 40% had more than 10 millimeters midline shift. I think it's important to say that the vast majority of the patients in this study had a primary evacuation of their chronic subdural. That's in keeping with the UK practice. And you can see that actually only 6% did not have an operation. And again, the vast majority had bare hole evacuation, and the vast majority had a subdural drain inserted. Again, that's in keeping with the UK practice. So moving on to the results now, and I'll just take you through this graph. So you have the modifier ranking scale, and this is a stacked bar chart. So you have the percentage of the patients on the y-axis, and then on the x-axis you have the MRS at discharge 3 months and 6 months, and you always have the dexamethasone group on the left, placebo on the right. And you can see that at discharge, oh, and I forgot to say that the good outcomes have the lighter color, so blue, green, and then the poor outcomes start from this kind of yellow, amber, and red. And you can see that at discharge, pretty similar, but then at 3 months, you start seeing this divergence between the outcomes for the two groups. So you have more worse outcomes, poor outcomes in the dexamethasone group, and this persists at 6 months. So looking at the primary analysis, so this is the good outcome at 6 months, and this was achieved at 84% of the dexamethasone group versus 90.3 in the placebo group. So that is a significant difference of 6.4% in favor of placebo. So actually the medication the dexamethasone was harming patients. And you can see the p-value and also the confidence interval confirming that these are statistically significant differences. And when you look at the ordinal outcomes, this is the sort of spread, but you can see that there is the proportion of patients who died was higher, and also the proportion of patients with who were very disabled, bedridden, was higher. And then when we did a couple of adjustments for age and the GCS on admission, again, you can see that this is still statistically significant difference, as we would expect, because age and GCS were comparable between the two arms. So this doesn't make a difference. And then also the per protocol analysis that I mentioned before, again, that showed a similar result, again, in favor of placebo. And that's the MRS at 3 months, which, as I said, that was also different. The difference was actually even higher at 8.2% in favor of placebo, again, statistically significant. Looking at some secondary outcomes, I did mention about the mortality already, so I won't discuss it again, but I want to highlight the recurrence, because that's also important, and that was one of the reasons that we did the study for. So in fact, you can see that repeat surgery for recurrence was much lower in the dexamethasone group, so 1.7% versus 7.1 in the placebo. And that was significantly different. But also, if you look at the adverse events, you can see that they were much higher in the dexamethasone group. And you can see in this slide some of those side effects. So these are mostly diabetic complications. So, new onset diabetes or hyperglycemia, which you can see in the top 2 rows there. And then also in terms of psychiatric issues, you can see that it was higher, and also the gastrointestinal problems, so, peptic ulceration. The relative risk just crossing 1, but in terms of the other, they seem to be higher. And then this is all the adverse events not just the special interest ones. And again, you can see that in terms of infections, it did seem to be higher in the dexamethasone group, and also the, as I said, the rest of the complications. Looking at the subgroup analysis, they didn't really show a difference, but I think it is worth highlighting those patients who did not have an operation during the 6 months of the study. And this was, as I said, 6% of all patients, so 38 patients, so a very limited sample size. But interestingly, 82% of the dexamethasone group out of those conservatively managed patients had a good outcome at 6 months, as opposed to all in the placebo group. So again, the direction of the effect is similar to the primary analysis. So in conclusion, what we found is that among adults with asymptomatic chronic subdural, most of whom had an operation to evacuate their hematoma, treatment with dexamethasone for 2 weeks resulted in fewer good outcomes and more adverse events at 6 months. But the number of repeat operations for a recurrence was lower in the dexamethasone group. In terms of the implications for clinical practice, I think that this study has clearly shown that patients treated with dexamethasone did worse than the placebo group. I don't think there is any doubt about that. This is a high-quality randomized study, and the results at 3 months and 6 months are consistent, and also all the secondary analyses are consistent. The majority of patients had surgery, so I think we can be very clear in saying that dexamethasone should not be used as an adjunct to surgery. And as I said, the conservatively managed patients was only 6%, so we'll be less confident in stating that dexamethasone should not be used as a standalone therapy. But as I said, the subgroup analysis was also consistent. So based on these results, we are recommending that the use of dexamethasone for chronic subdural should be avoided unless it is happening as part of a research study. So for example, I know that our Dutch colleagues, they ran a study of dexamethasone versus surgery. And this is going to give us an idea about the utility of dexamethasone as a standalone treatment, perhaps before surgery. Finally, I think it's also worth repeating that we have established that surgery for chronic subdural has a very good safety profile. So 90% of the patients in the control group had a good outcome at 6 months. So these are patients who are old and they have lots of comorbid conditions, but they can do very well. And almost 2/3 went back to their usual duties and activities. The recurrence rate is getting lower. So the 7% of the control group is one of the lowest ever reported in a multi-center study. So in our view, in the future, we should try and focus on the role of rehabilitation and perhaps integrated neuro-geriatric care. So trying to follow the model of ortho-geriatricians who have improved the outcomes of patients who have a hip fracture, for example. Evaluate the role of minimally invasive techniques, so the bedside twist drill craniostomy. I know that middle meningeal artery embolization is becoming quite popular in the United States. I think it is worth studying these investigations properly with proper studies, looking at when to restart antithrombotics. So as I said, half the patients were on some form of anticoagulation, and also trying to improve trial methodology. And Ellie Edelman, the research fellow of this study, is doing some work on this. So that's pretty much everything. Obviously, as I said, many people to thank, but also the funder. So this study was funded by the UK National Institute of Health Research with £1.4 million. Without funding, this study wouldn't have happened. Of course, the patients and their families, and also all the collaborating clinicians and the research staff, the steering committee members, and the data monitoring and ethics committee members. So Martin Smith and Tony Belly were the chairman, and also the Cambridge Clinical Trials Unit. And as I said, you can access the full paper on nejm.org. If you register, you can access the whole paper for free. So that's pretty much everything I had to say, and don't know if there are any questions.
Thank you very much, Dr. Kolias. A very interesting topic, very interesting paper discussion and research. Chronic subdural is becoming quite common, especially because of the increasing elderly population in the developed countries with the patients on blood thinners and thrombolytic agents. Just a couple of points I want to clarify. Uh, the number of burr holes, was that consistent with 2 burr holes? I would like to know, and whether what type of drain was put in. Also, very interesting that the recurrence, it appears, is less with using steroids, although the outcome otherwise is not good. And I wonder whether one would consider doing a larger international study through NIHR on this particular topic. Thank you.
Yes, thank you. So very good questions. So yes, the vast majority were, so because most of the operations in the UK are happening under a general anesthetic, so the vast majority is 2 burr holes. There are some very few patients who had single burr hole under local anesthetic and a few mini craniotomies, but I say the vast majority is 2 burr holes under general anesthetic. In terms of the subdural drain, again, the vast majority is subdural drains, so subgaleal subperiosteal drains would typically be used if the brain has re-expanded and it would be unsafe to put the drain subdurally. And in Cambridge, we use a soft silicone drain, just gravity, so no suction. I know that in some other units, they use, for example, an EVD as a subdural drain. So, that can also be used. But we didn't look specifically to see if there was any difference between the different types of drain. I think that was outside the scope of this study, but that's an interesting question. In terms of doing, I mean, yes, you're right. It's very interesting that the recurrence was lower, but the outcomes were worse at 6 months. And it would be interesting to try and speculate why. I suspect it must be because of the adverse events. And these are elderly patients, so even the 2 weeks of steroids probably led to more adverse events and then led to worse outcome at 6 months. I think that's the only plausible explanation. But at the same time, I think you make a good point. Is there any scope for a further study? I mean, potentially yes, and we have been discussing this a lot. Perhaps a lower dose schedule, and perhaps for a week rather than 2 weeks. I have to say that we decided on this, the 2-week course, on the basis of previously published studies. And actually the 2 weeks is one of the lowest. So many randomized trials, even ongoing ones, and many other studies, they have been using steroids for 3 weeks, 4 weeks. There are some that are using it for 3 months. So the 2 weeks is one of the lowest, actually. But yes, I think, potentially there may be scope for a further study, lower dose, shorter duration. The problem is that I think it will be very difficult to convince a funder to fund such a study. Simply because, when you have a big, 750 is a big study, but when you have a study that has shown worse outcomes, more adverse events, I think it'll be very difficult to convince a funder to fund such a study. But yes, I think, it will be interesting.
Raja?
Yes.
That was an excellent talk, Angelios, and we learned a lot from the results of that trial. But let me ask you something which is unrelated, which is now people are just telling and found evidence also, including Raja has also published. What is your take on tranexamic acid for chronic subdural hematoma? And many studies have come right from 2013 from, I think, Kajiyama from Japan, Mikulis, and I think even Raja has also published results of tranexamic acid. Can you just tell your views?
Yes, I mean, I think it's an interesting agent, obviously. It is very cheap. It's very easy to get hold of tranexamic acid, at least in the UK. I know that this is the case. So it is definitely interesting, and it's something that we have thought about, potentially, using as part of a research study. And I know that there are a few ongoing randomized trials of tranexamic acid, but I don't think that I've seen any results from a randomized trial obviously, I've seen the various case series describing the use of tranexamic acid. So I think that it is worth studying this, but I think the point is that unless we do a randomized study with a placebo, etc., it'll be very difficult to conclude from non-controlled studies if they help. I think the study that I just presented is a good example of why this is the case. Up to now, people were thinking that steroids in chronic subdural, on the basis of the previously published results, are potentially useful. But yes, we have some that they are useful. They can reduce recurrence, but actually that's at the expense of worse outcomes at 6 months, significantly worse outcomes. So I think that's why, unless we do proper randomized control studies, especially with these kind of pharmacological agents, we won't get the answers we need. I'm not saying that randomized trials are needed for everything, so I'm not saying that, of course not.
Professor Angelos, but I understand there is a trial which is going on called TRAX trial.
Yeah, that's right, yeah.
Yeah, and so I think the results will be out. Whatever it is, the results are encouraging, especially for those patients who are on blood thinners, like Tariq was telling, and anticoagulants. Here is one drug which can be given at the same time you can continue anticoagulants. Okay, Raja can probably put in a word more.
Thank you, Professor Suresh Nair for that comment. Actually, the one concern of tranexamic acid is regarding the safety profile of the drug. So, although it has been never proven in a randomized control trial, except one study where patients had increased incidence of thrombosis from tranexamic acid. But that is the only concern that I have come across among many discussions which have been following my article about tranexamic acid in chronic subdural hematoma. As Professor Kolias mentioned, definitely we need a control group. Without control group, there is nothing to take from a paper except that it may or may not work. That is my final. We hope Professor Kolias will embark on another study regarding tranexamic acid, and
I'm not sure if I want that.
We are open to that anyway.
It's a lot of work. Can I say it's a whole team, and but anyway, I think it's a good idea, the tranexamic acid.
Yeah, one question from Dr. Uday Gupta. Yes, Professor.
The number of burr holes, 2 versus 1, which is better? I mean, 2 burr holes for a chronic subdural, or we can work out with single burr hole also. And my second is in recurrent chronic subdurals, the superiority of embolization of MMA over a craniotomy.
Yeah, again, very, very good question. So, as I say, I think if you are, if you're giving somebody a general anesthetic, I really can't see the point of using just a single burr hole. The patient is anesthetized. You might as well do burr holes, 2 burr holes, one sort of frontal, one over the parietal boss, and just get good clearance. On the other hand, as I say, we do most of our case under general anesthetic, but if you're using local anesthetic, often it is difficult. The patients can move a little bit. It's not easy to get a good, broad surgical field and maintain, a clean field. So in those cases, I think there is a role for single burr hole. But if somebody's getting anesthetized with a general anesthetic, personally, I can't see the point. And then the second part of the question was
in recurrent chronic subdural hematomas.
Yes.
Would you go for a craniotomy, or we'll start with the embolization of MMA?
Yes, I think again it depends a little bit on the scan appearances. So if it is just one recurrence and the scan doesn't show any multiloculated collections, it doesn't show several membranes, you could just simply open up the burr holes again and have a look and see if you can, get a better result next time. I think if you have now 2 recurrences, then this is when I would start thinking about doing something more, potentially a craniotomy. MMA embolization is not really being used in the UK. I think, in general, our interventional radiologists, they're a little bit stretched at the moment with the embolectomies for stroke, and also the rest of the work that they do. So it's not really been used, but I can see a role for a subdural with more than one recurrences. I can see a role in the future.
Thank you, sir. Thank you.
Thank you very much.
Yes, Professor Omar, you want to ask?
Hello, all colleagues. How are you?
Hello.
Dr. Raja,
thank you very much.
Dr. Golias. I asking about antithrombotic on head trauma, especially head trauma, and there's comatose and nothing obvious in the CT scan. I think there's some thrombosis at the midbrain. You see, I give Flexan, mild, sometimes mild, 40 per day. Okay, antithrombotic. There's some thrombotic in my experience, thrombotic in the midbrain, especially in head trauma. What's your opinion, please?
Yes, I think that's what he's saying. In the thrombosis in the midbrain, suggestive of?
CT nearly normal. Let's explain. Let's explain what the comatose. There's something.
Oh, I see. I see what you mean. Oh, okay. So So you're thinking some sort of deep venous thrombosis or something like that in the. Okay. I would say. I mean, Professor Khan can also answer this, but I would say that this is, slightly unusual in terms of, getting thrombosis of the, of the deep venous system in head trauma. I would say that, it is far more likely that if the CT scan is normal and the patient is in coma, that if you do an MRI scan, it might show, diffuse axonal injury type problem, rather than, I would say that this is far more likely as an explanation for somebody who's in coma.
We have no MRI.
Yeah, no, but I agree. I agree with Angelos. It would be more of a diffuse axonal injury than a thrombotic event. So giving antithrombotic, I'm not sure whether that's going to be of any benefit.
Right. Yes, my co-host Liubun saying.
Thanks, Roger. Thanks, Professor Golias, for a nice presentation. I have a few questions, Prof. You mentioned that in your study, the DEXA do help to reduce the recurrence. May I know that within that group, do you have any sub-analysis looking at the type of chronic subdural, whether they are more of a homogeneous type or the other types? My second question, Prof, is there any study looking at using a purified dexamethasone for local effect? As you mentioned, 97% of your case are operated. So whether, because other specialty, they are using local effect, then that will be reduce problem with the systemic effect of the dexamethasone. My last question is, as far as I think my concern is chronic subdural in my training, is considered the most rewarding surgery because patient you usually full recovery after surgery compared to any other neurosurgical procedure. So would you think that in the future, the MRS will not be grouped together for 0, 1, 2 group, whether we will aim for a better recovery, either group MRS 0 or 1, to look at the good outcome, Professor? Thank you.
Yes, thank you. So very good questions, all of them. I think, in terms of the CT findings, and sorry, I'm just trying to bring up the appendix. I'm just in it at the minute, but it was more or less what you expect. So most of the patients had mixed density collections, hypodense, isodense, and some of them, yes, they did have small hyperdense components. So but the vast majority is more or less what you expect in terms of the CT scan findings. I think the point that you are raising about topical steroid, I think that's a very good one, and we have thought about it. And all I can say is that, as far as I know, there isn't a form that has been approved for use directly in the subdural space. But I think that this is a very good idea, and yes, we have thought about it. That makes sense to avoid the systemic side effects. In terms of, I agree that this is a very rewarding operation, and I think we have shown that the outcomes are very good. So, for somebody who is 75 and with many comorbidities, I think 60% going back to how they were before, that is very good. Admittedly, you know, the MRS3 is one of those categories that some people would say actually that is maybe not a very good outcome. But still, I think, you know, if you have somebody who is 75, frail, with quite a few comorbidities, I would say that 3 is acceptable. But at the end of the day, you have to put it to the patients. But yes, you know, I think you're right. We should be striving to improve the outcomes further. And I mean, I can see an increasing role for geriatricians. You know, these patients are becoming medically more and more complex. So I can see an increasing role for geriatricians in the future in terms of the post-operative management.
Thank you, Professor.
Thank you.
Thank you. Thank you very much. In the same vein, I would like to mention that when I started my study of tranexamic acid, there were similar opinions from many seniors that why don't you just put some tranexamic acid for on the local site for preventing recurrence. But actually, when I went to the literature, I found that actually Johnson & Johnson came up with this idea long back with surgically impregnated tranexamic acid, but it was withdrawn from the market due to high incidence of seizures. That's why it was not, it is not recommended to use tranexamic acid in local administration. So I would like to go back to our honorable chair. Thank you very much, Professor Angelos Koulias. It was a wonderful learning experience. We will have final comments from Professor Tariq Khan.
Yeah. Thank you very much. A very good interaction and good discussion on all this. And I still believe that there's a lot to be looked at in this because this is an elderly population more and more, and a lot of patients are the ones who may not be amenable to surgery because of comorbidities or as little surgery as possible. So one can look at the role of steroids and tranexamic acid in different forms to see whether even surgery can be avoided or not. Thank you very much.
Great. Thank you very much.
Thank you. Thank you very much. I understand that both the first speaker and the chair have to leave. Professor Tariq Khan is on his Ramzan fast and he has to break the fast. Thank you so much for joining today. We are indeed so very much honored today to have such a wonderful speaker and chair for our webinars. Thank you very much for both.
Thank you very much. But I will definitely watch the next lecture on YouTube because I think it'll be on YouTube, right?
Yeah, we'll be sending it to you.
I'll definitely watch it. Thank you very much.
Thank you.
Thank you, Professor.
For me, I want to say hello to all the participants and to thank Professor Kenichi Oyama for presenting, which has been our topic for 20 years, the skull base through the endonasal way and the endoscope. And I want also to thank Professor Yoko Kato of the Asian Congress of Neurological Surgeons. So for me, it's a great pleasure to be among this wonderful group. And I am sure that Professor Oyama will make a superb job. I've been 2 times in Japan, and it's a country of precision and excellence.
Our second chair has left, Professor Paolo Capabianca has left. Nevertheless, we have our dear friend Alberto Feliti with us. Maybe he can share this session for us. Feliti? Yeah.
Yes. Hi, Raja.
Thank you.
Hello, everyone. Nice to see all of you. So I could join you in a rush because I am at hospital. So next speaker of this webinar is Professor Kenichi Oyama, who is director and professor of the Department of Neurosurgery, International University of Health and Welfare at Mita Hospital in Tokyo, in Japan. And he will talk about a very interesting topic about endoscopy, in particular endoscopic endonasal surgery, the sagittal plane module. I am personally, and I think all of us are very interested in knowing about this. So I want to ask Professor Oyama to start his lecture.
Thank you, Professor Ferretti. I'm going to share my presentation. Thank you, Chairman. So I'd like to express my sincerest gratitude to Professor Yoko Kato and Professor Kati for giving me this great opportunity. First of all, I'd like to introduce my university hospital. Our university and our medical school established recently. Actually, it is very unique because we accept a lot of foreign students for our medical university, and I'm sure they will play a great part in their country within a decade or so. And my hospital is one of the 6 university hospitals of IUHW. It is located in the center of the Tokyo and very close to the Tokyo Tower. So you can enjoy a beautiful scenery of the Tokyo Tower from our hospital. So please visit our hospital after the pandemic and enjoy the beautiful scenery. As you know, the endoscopic endonasal approach, the concept of the approach is mainly established by the Professor Kassan. He is one of my great mentors and one of my good friend. And it was the cutting edge technique for the ventral scalpus region at that moment. But nowadays, it's been one of the standard technique for the ventral scalpus regions. Today, I have 14 minutes for my presentation. So I'm going to talk a little bit about the basics of our endoscopic endonasal approach, and then cover the entire modules. I'm talk about the sagittal plane modules, and then go to the coronal plane modules. As you know, we have several kind of endoscope for this maneuver. And actually, I'm using this type of endoscope. This is the product of the Olympus in the Japan. You can see that this endoscopy is integrated with the pneumatic arm. So we can mobilize this endoscope during the operation very easily. So we use this endoscope not only for the endoscopic endonasal approach, but also for the open skull-based endoscopic approaches. For the endonasal approach, we usually perform the unilateral approach for the most of the theral tumors because it's really simple and less invasive approach. This slide shows you the nasal part of this approach. We usually cut the nasal mucosa at the in front of the middle turbinate, and then dissect the mucosa from the nasal septum toward the sphenoid sinus. It's very simple and very easy. This is a picture after the operation. Performing the unilateral approach, we can preserve the normal anatomy of the nose and the mucosa almost intact. This is a case of pituitary apoplexy. He was developed with the severe visual disturbance and pituitary dysfunction. We treated this patient using a unilateral approach. We usually put the endoscope in the lower part of the surgical field, and we use the upper part for the surgical maneuver. You can see that this tumor had a hard consistency, probably due to previous hemorrhage. So in this case, we could perform the extra capsular removal of the tumor from the dissecting between the normal pituitary gland and the tumor. Finally, we could perform complete removal of the tumor. I'm now confirming the lateral part of the tumor. And we usually perform the bilateral approach for the complex scalpus lesions. As you know, the paraseptal approach is very simple and less invasive. On the contrary, by nostril approach, we have to open the normal nasal anatomies to get the tumor. So it's a little bit invasive approach. To perform EEA safely, you have to know the several hemostasis techniques to control the bleeding during the operation. Actually, the warm saline irrigation is useful for the mucosal and bone bleeding to some extent. Bone wax is, of course, for the bone bleeding, and we usually use the monopolar cautery for the mucosal and the bone bleeding. We have several kinds of hemostatic agents. They are mainly used for the venous bleeding. And of course, the bipolar cautery is very important for controlling the arterial bleeding. For venous bleeding, the first thing you have to do is to elevate the patient head to reduce the venous pressure. After that, we usually apply a hemostatic agent. Actually, we have a conventional hemostatic agents like Abitin, Sagittal, gel form, etc. But actually, those agents are a little bit difficult to place in the deep surgical field because those products tends to stuck to the nasal mucosa. Professor Kassam reported the utility of Abitin sandwich many years ago. Actually, it was really useful. But nowadays, we have a flow of hemostatic agents like a surge flow and frost seal. Those agents are really useful for the endoscopic endonasal approach, I think. This is a case of a small prolactinoma. You can see the tiny tumor in the right side, but actually the tumor was invaded to the medial cavernous sinus. So this is a surge flow. It has a flexible tip, so it's really useful inside the nose. You can see that the surge flow has a hard consistency, so they stay there, and we can control the bleeding very easily. In the functioning tumor, we usually perform the extracapsular removal of the tumor to perform the complete remission of the endocrine function. In this case, we remove the tumor inside the medial cavernous sinus, and also we remove the medial cavernous wall. After that, we usually have a venous bleeding from the cavernous sinus, and then just you have to you apply a flowable material like this and put that using a cottonoid, and it's easy to use. Post-operative MRI showed the complete removal of the tumor, and we also achieved the complete remission of the hyperprolactinemia. We have several kinds of bipolar cautery. Upper one is the product produced by Professor Capabianca. Those instruments has a single shaft. It's really easy to use inside the nose. To perform a bone work inside the cavernous sinus, you have to imagine the place of the ICA through a bone window. One of the most important anatomy inside the sphenoid sinus is the lateral OCR. You can know the place of the ICA using this landmark. Actually, the ICA injury is rare and very dangerous complication during the EEA. When you encounter the ICA injury, I recommend you to compress the cervical ICA first. Then you have to keep the lens clean. and find a bleeding point with suction, and then try to bipolar coagulation. It is sometimes effective, but not always. So one of the most standard technique for the ICA injury is a packing with a crushed muscle graft. And then, of course, you have to go to the angiography suite to confirm the presence of the pseudoaneurysm. Actually, it's a very dangerous and disastrous complication during the EEA, but the ICA injury is very rare. So we developed the training model for the ICA injury when I was in the Ohio State University. This is a product from the Japan medical company. I'm going to show you the video. Now I'm drilling the ICA. You can see that they're bleeding from the ICA. First thing you have to do is clean the lens and find the bleeding point. Then place a crushed muscle over the ICA and compress the ICA. After that, you have to go to the angle suite. So now I'm going to talk about the sagittal plane modules. This yellow straight line seems to be an anterior limit of the sagittal plane modules. But actually, we can get to the frontal sinus using the angled scope. Using the draft 3 technique, we can open the septum inside the frontal sinus and make a wide corridor to get to the tumor. This is a case of recurrent basal cell adenocarcinoma. We perform the endoscopic approach to remove this tumor. And the lateral limit of this approach is the optic nerve. So actually, we could remove the tumor located midline inside the optic nerve. You can see here. And the remnant of the tumor was removed using the small craniotomy. Transcribriform approach is one of the good options for the anterior skull base tumors. To get to that area, you have to manage the ethmoidal arteries. Those arteries are branches of the ophthalmic artery. This is a picture from the cadaver. In the left side, bone is still intact. In the right side, bone has been removed. You can see the bony protuberance of the ethmoidal arteries. So you have to find those arteries during the protidia and control the arterial bleeding. And also, after opening the orbit and pressing the orbital content laterally, you can easily find those bundles during the operation. This is a case of olfactory groove meningioma. The first thing I did was to find the ethmoidal arteries. Now I can find the ethmoidal artery here, and coagulate it and cut. After performing this, it was really easy to remove the tumor without massive bleeding. Actually, the transplanum, transcerebral, and the transcribal approach is the most popular approach of the endoscopic endonasal approach. To perform the transplanum approach, you have to open the posterior ethmoid to create a space for your surgical maneuver. Lateral limit of this approach is the ICA. This is a case of huge craniopharyngioma located in the anterior skull base to the posterior fossa. So in this case, of course, we perform the transplant approach to remove the tumor. And also, we plan to perform the transcriber approach for the posterior part of the tumor. Luckily, we can remove the tumor just using the transplant approach. You can see the tight adhesion to the optic nerve. So we sharply dissect the tumor from the optic nerve. And luckily, we could perform the complete removal of the tumor. After postoperative MRI also confirmed the complete removal of the tumor, and we could preserve the pituitary function. And the outcome of the visual function is also acceptable. This is a case of huge tuberculous cell meningioma. One of the key techniques for performing the endoscopic endonasal approach is a reconstruction. I'm going to show you the one of our standard technique for the reconstruction. We usually try to keep the mucosa inside the nose for the later reconstruction, and then perform the craniectomy like this. After opening the dura, we dissect the tumor from the arachnoid plane, but the tumor lost the normal arachnoid plane and adhered to the artery and optic nerves. So we carefully and sharply dissect the tumor from the optic nerve and the ACAs. I'm using the sharp dissector. It's from the Karl Storz. Finally, we could perform the complete removal of the tumor. After that, we usually have a huge dural defect like this. So we usually put the fascial lata inside the dural defect and make some stitches to create a duroplasty nearly watertight fashion. This is the final view of the dural closure. And after that, we cover the dural defect using the polyglycolic acid sheet. This is the material available in Japan for the dural reconstruction. It is very useful. And then we put the bone back there and cover it with the PGA sheet again and place the mucosa back over the bone. In this case, we didn't use the nasoseptal flap, just using the mucosal flap inside the sphenoid sinus and cover it with the fat and fibrin glue. That's it. Post-operative MRI showed the complete removal of the tumor, and the post-operative clinical course was uneventful. And the translator and the transcriber approach is very simple and straightforward to the region. For performing the translator and transcriber approaches, you can preserve the normal anatomy inside the nose. Lateral limit of this approach is the ICA. But there is one thing you have to control during this procedure: the pituitary gland. If you want to the behind the pituitary gland, it is actually the interventricular fossa. You have to mobilize the pituitary gland. Professor Kassan reported special technique to get to the interpeninsular fossa. Pituitary transposition. You can mobilize the pituitary gland from the cavernous sinus wall and put it up. And after performing this, you can remove the posterior clinoid and cut the dura. After performing this, you can get to the interpeninsular fossa from the nose. Actually, we have good open cranial-based approaches to the interpeninsular fossa. It was described by the Professor Hakuba many years ago, posterior transpetrosal approach. Using this approach, actually we can get a great access to the interpeninsular fossa. But I was not sure which approach is better to get to this area. So we compared those two approaches using this water balloon. You can see that the tumor, that water balloon tumor, is connected to the syringe. So we can control the you can control the volume of the balloon using this syringe as you like. So you can see upper two pictures is a endoscopic approach, and the lower picture are from the open transpetrosal approaches. So you can see that the endoscopic approach provides a better visualization of this area. So I think this endoscopic approach to the interpeninsular fossa is more useful than the transpetrosal approaches. But in the huge tumor, in the case of huge tumor, the tumor itself created a wide corridor for the surgical maneuver via the transpetrosal approach. So I think for the huge tumor, the transpetrosal approach is still one of a good option to treat the tumor in this area. And actually, I was not sure after performing the pituitary transposition whether we can preserve the pituitary function or not. Actually, the first report from Professor Kassan told us it is very easy to keep the pituitary function, but actually it was a little bit difficult to keep the pituitary function after performing the pituitary transposition. And later, in 2014, the Fernandez Miranda in the Pittsburgh group reported a new technique for the transposition. They called this the Inter-Carbonace Transposition. They keep the pituitary gland attachment to the one side of the cavernous sinus. After performing this, usually the pituitary function is keep normal. I'm going to show you the one case. This is a 67 years old male. He has a huge petroclival meningioma. It was located from the PCA to the jugular foramen. So what would you do for this type of tumor? There are a lot of indications for this type of tumor. Anterior transpetrosal approach, anterior transpetrosal with the retrosigmoid combined transpetrosal approaches, and endoscopic and retrosigmoid combined. In this case, we selected the EEA because the thick nerve was involved in the tumor. Only using the EEA, we can get to the thick nerve firstly. So I'm going to show you the video. The bone has been removed. I'm now cutting the cavernous wall. You can see the inferior hypophyseal artery. We have to coagulate and cut the inferior hypophyseal artery and controlling the venous bleeding using the flowable material. After performing this, we can remove the posterior clinoid and mobilize the pituitary to get to the interventricular fossa. In this case, we cut the clival dura like this. You can see the tumor just behind the dura. Tumor has a hard consistency. We removed a little bit the specimen for the pathological diagnosis. And after that, we use the ultrasonic aspirator to remove the tumor. You can see the pons behind the tumor. And then cut the dura toward the cavernous sinus. After that, we can remove the tumor in the interventricular fossa. You can see the tumor on the basilar arteries. Here is the third nerve. We dissect the tumor from the third nerve carefully. Here is the third nerve and the tumor. Carefully remove the tumor using the scissors or sharp dissector. And finally, we could remove all of the tumor. I'm going to skip the video a little bit. And one of the important anatomy in the transcriber approach is the sixth nerve. Sixth nerve is coming from the pons medullary junction towards the Doredus canal. So you have to preserve those nerves during the transcriber approach. So in this case, we use the nerve stimulator and find the sixth nerve in the pons medullary junction and follow it toward the Doredus canal, dissecting the nerve from the tumor. After performing this, we could mobilize the tumor over the sixth nerve, and then we can safely remove the tumor, preserving the sixth nerve completely. This is the final MRI, postoperative MRI. We could perform the nearly total removal of the tumor. This is this slide shows you the lower limit of the sagittal plane modules. The originally blue line seems to be a lower limit of the endoscopic endonasal approach, but actually the yellow line and the purple line is the lower limit of this approach. Performing this approach, you can remove the C1 and dens and remove the tumor in this area. This is a case of craniocervical junction chordoma. We could perform the gross total removal of the tumor using this approach. So now I'm going to talk about the coronal plane modules. Endoscopic approach to the lateral skull base. The lateral skull base there is two lateral skull base, upper lateral skull base and lower lateral skull base. Upper lateral skull base include the cavernous sinus and orbit. To get to the cavernous sinus, you just open the posterior clinoid to create that space for your surgical maneuver. During the procedure inside the cavernous sinus, you need to monitor the cranial nerves. This is a simple eye movement monitor using a piezoelectric device. we reported the utility of this monitoring many years ago. Nowadays, we use needle monitoring, NIM response like this. This case is acromegaly. This case has invasion into the cavernous sinus. So we remove the tumor inside the cavernous sinus, keeping the ICA intact as well as the cranial nerve intact. In this case, we perform the uninostril approach, and just opening the posterior ethmoid, you can get to the medial cavernous sinus like this. To get to the orbit, you have to open the ethmoid completely. You can see that we usually remove the laminar papillacea first, and then find the optic canal and follow it toward the pituitary fossa. This is a case of traumatic ophthalmopathy. So I open the laminar papillacea first and find the optic canal, and then drill over the optic canal toward the pituitary fossa and remove the bone completely over the optic canal to the laminar papillacea. Lower lateral skull base includes the petrous apex, parapharyngeal space, and the condyle. One of the good candidates for the lateral approach is the petrous apex cholesterol granuloma. We reported the utility of endoscopic approach to the petrous apex cholesterol granuloma in 2007. And if you want to get to the lower lateral skull base, you have to open up the ethmoid sinus completely. And one of the key procedures is the transpterygoid approach. And there is two important anatomies. One is the Vidian canal and one is the foramen rotundum. You can follow the Vidian canal toward the petrous ICA, and you can preserve the ICA during the drilling if you keep the Vidian canal intact. This slide shows you the surgical anatomy of the transpterygoid approach. Firstly, you have to find the sphenopalatine foramen and remove the bone from there, keeping the periosteum intact. Then you can find the Vidian canal, and you can cut the Vidian nerve to mobilize the content of the pterygoid laterally, and then you can drill below the Vidian canal toward the petrous apex. This is the final view of this approach. Using the 0-degree scope, you can see the ICA, third nerve, sixth nerve, B1, B2, B3, like this. This is a case of recurrent Cushing disease. So we perform the transpterygoid approach. We just a little bit pterygoid space to get to the cavernous sinus. And after that, we remove the tumor completely from the cavernous sinus. And we could perform the good endocrinological remission of the Cushing disease after the operation. And this is another case of the Meckel's-Cave tumor. Now I'm finding the Vidian nerve and cut the nerve. to create a space for your surgical maneuver. After performing this, we can drill between the B2 and biliary canal toward the petrous apex and follow the B2 toward the gastrian ganglion. And after that, we remove the tumor inside the Meckel's cave from the nose. This is the final approach of the lateral lower skull base, infratemporal fossa approach. To get to the infratemporal fossa from the nose, you have to cut the inferior turbinate and make a maxillectomy toward the pterygopalatine fossa. Open the pterygopalatine fossa. You can find the foramen rotundum, biliary canal, pterygoid body, lateral pterygoid plate. And then you have to follow the lateral pterygoid plate to the foramen ovale. Finally, you can get to this area from the nose. Of course, the navigation system is useful to find the foramen ovale using this approach. This is a case of huge recurrent meningioma. You can see the tumor located in the infratemporal fossa as well as in the inside the nose. So we decide to perform the endoscopic approach to remove the tumor. You can see the tumor in the center of the view. The tumor had the hard consistency, so we need an ultrasonic aspirator to remove the tumor. So it's the same to remove the convexity meningioma. So it's a really tough tumor. We make an internal debulking and remove the tumor piece by piece. And finally, we couldn't reach the deepest part of the tumor using the ultrasonic aspirator. So we could perform the partial removal of the tumor. But after that, we perform the open approach to the remnant of the tumor. This is the almost final slide. We describe the surgical boundaries of endoscopic endonasal approach for the ventral skull base regions. Understanding of surgical anatomy is mandatory for treating complex skull base regions via endoscopic endonasal approach. Less invasive and appropriate approach should be applied depending on the size, location, and type of the lesion. So it is very important to know the anatomy. Actually, we have a yearly skull base cadaver dissection course in the Taiwan area. You can see the Professor Kawase here. He is performing the Kawase approach in the lab. Actually, we had last year we couldn't hold this kind of a course, but this year we may have it in the Taiwan. So please join there and enjoy the dissection together. Finally, I'd like to say thank you to my great colleagues in IUHW, Nippon Medical School, the Ohio State University, and Paris University. And thank you for your attention.
Thank you very much, Professor Oyama, for this wonderful lecture. Really, you showed impressive cases. I think it's a very useful talk because you talked about the limits of this endoscopic approach, especially for the extended approaches. Actually, I have some questions, then I will leave, of course, space to the audience. You talked about these limits, anatomic limits. My first question is, when you have to decide whether to go with endoscopy or craniotomy, do you base only on these limits, or you consider also other characteristics, like, for example, vascular encasements or relations between the tumor and important vascular or nerve structures? This is my first question. The second question is how much training, and this actually this question connects to your last slide about cadaveric dissection and courses. How much experience do you have to gather to be able to completely use these limits for the extended resections that you showed? Thank you.
Thank you, Verity. It's a very good question and very important question, I think. The limitation of this approach is actually the vital structures like cranial nerves and the vascular anatomies. So the tumor is inside the nerve or vascular anatomies. You can get to the tumor using this approach. But the tumor located outside the nerve or vasculatures, you have to choose the open approach to get to the tumor. It's much easier and safer to get the tumor. So you have to think about the location of the tumor depending on the normal anatomy of the vital structures. This is the question, the answer for the first question. And the second question is also important. As you know, the Professor Carl Schneiderman in Pittsburgh reported the learning curve. You need a learning curve to know the details of the surgical approaches. And the first thing you have to treat using the endoscopic endonasal approach, the good candidate for the beginners, I think the cystic tumors, like a Lato's cyst or cystic adenomas or arachnoid cysts, etc., because it is very easy to remove the contents using this approach, and you don't need to treat the ICA or optic nerve, etc., vital structures. And generally, you need at least 15 cases like cystic tumors. After that, you can move to the adenomas, small adenomas, or maybe macroadenomas. It depends. But for the pituitary surgeons, micro-functioning adenoma should be treated by the expert, because the functioning tumor should be removed completely. So it's not for the good cases for the beginners. And actually, for the theta tumors, craniopharyngioma is very difficult to treat. So the first thing you have to for the beginners to do is to watch the operations done by the experts. And if it's possible to join the operation as an assistant and experience a lot of cases as an assistant, after that, you may try to treat the tumor by yourself. But of course, the cadaver dissection is very important and very useful to learn the techniques in the lab. Thank you very much.
Thank you, Professor. Yes, I also think that cadaveric dissections for this kind of approach are very important. Maybe more important for this kind of approach compared to craniotomies and so on. I want to ask Raja or you or anyone in the audience for more questions for Professor Oyama.
Thank you very much, my dear friend Alberto. Professor Oyama, that was a very wonderful lecture, and we had a great visual treat about endoscopic endonasal surgeries, whereby you stretch the boundaries of excellence into very difficult corridors otherwise once considered impossible. Thank you so much. One question that I would like to ask you, that you showed one first video that you showed it was a prolactinoma. And so what are your indications in surgery for a prolactinoma?
Thank you, Raja. Actually, we use a dopamine agonist first, most of the cases. But I think the tiny enclosed tumor is a good candidate for the surgical maneuver. And I always discuss with the patients, which do you want, using medication or surgery? It depends. Most of the patients wants to use their medication, but some patients wants to be performed operations. So it depends. Okay. The first thing, the medication is the first treatment. It should be.
Thank you so much. That's my co-host Liu.
Thanks, Raja. Thanks for Professor Omaya. We learned quite a lot that can be done through the skull base. I have a question regarding the replacement of the bone for skull base work. Based on your experience, what will happen to the bone piece that you replace in the follow-up imaging? Will they get resolved, or they will have a full bone healing and reconstruction? Thank you, Professor.
Yeah, thank you very much. It's a good question. But actually, the placed bone probably gone away. I'm not sure. But I treated many recurrent cases, which was treated at the another institution. There is some bony formation after the operation. So it depends. You can expect the some bony reconstruction after the op.
Thank you, Professor.
Right. Thank you so much. So I think if there are no more questions, we can wind this up. I will go back to my dear friend Alberto to give his concluding remarks.
Yeah. Yes, I think we listened to a very interesting lecture, as I said, because Professor Oyama was able to give us a clear picture of which the limits are for this kind of approach. And as we discussed, it's important to know the anatomy to understand these limits. And not only that, it's important also to consider other factors like encasements or vital structures, as he said. I think he mentioned a very important concept, which is the extracapsular removal for cellular lesion. I think this is very important to know, because if you insist trying to remove an adenoma only by entering the tumor without finding immediately the limit, the capsule, that maneuver can be very difficult, and it can be difficult to identify the limit of the tumor. Maybe the risk for remnants is higher in that case. So I want to thank Professor Oyama for really a wonderful lesson he gave to all of us. And Raja and you, thank you for organizing this webinar again.
Thank you so much, my dear friend Alberto, for sharing at such a short notice. We are indeed so grateful to you. So I'll wind this up officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers for today, Professor Kenichi Oyama, Professor Angelo Scolias, and the chairs, Professor Paolo Capabianca, who was there in the initial part of the meeting, and my dear friend Alberto Felletti, as well as Professor Tariq Khan, for coming here and lending their support for the ACNS webinars. Thank you all who joined, and we had a great learning experience today. So until we all meet on the 15th of May, it is bye-bye from all of us.